And hello, everybody. For those of you who don't know me, my name is Briana Cardenas. I am a physician assistant and also a certified athletic trainer. My clinical background is chronic pain management. So I've worked in pain management since 2013. I now work as a PA professor. So I teach future physician assistants how to essentially become PAs and be prepared for their licensure and so forth. But I am happy to report that every PA student that I've ever worked with will know how to recognize, diagnose, and treat EDS and related comorbidities, including spinal fluid leak, which I am like just beyond proud of. Like that's such a full circle teacher moment, and it like just totally fills my heart. I had coffee with a former student yesterday, and on her rotation, she diagnosed somebody with a CSF leak after multiple people had just told her, of course, that she was, just crazy and attention seeking. And my student was like, no, I remember that lecture on spinal fluid leaks. You've got a spinal fluid leak. And she caught it and treated it. And yeah, it was just like a super proud teacher moment. So I was super proud of her.
Properly. All right. So we are welcoming Briana Cardenas. I always do this right. I'm butchering it.
So like the English way to say it would be Cardenas, but like the way that I pronounce it is Cardenas.
Cardenas. Okay. I'm sorry. I should know that. I'm not great at very fast speaking. Okay. She will present on EDS and cerebral spinal fluid leaks, right? CSF leaks and chronic pain. And then she'll take questions. Briana is both a practitioner and a patient. She's a physician assistant, a certified athletic trainer, and a professional specializing in chronic pain management who has EDS, spontaneous cerebral spinal fluid leaks, cranial cervical instability, and dysautonomia. She's also a professor. Briana believes in responsible, integrative, compassionate care and works with modalities ranging from therapeutic stretching to
intrathecal pain pumps. Yeah, I've worked with actual like pain pumps that deliver medicine just into the spinal fluid for people that have severe intractable pain.
So intrathecal drug delivery devices. She emphasizes nutrition, exercise, and complementary alternative therapies for long-term success with managing chronic pain. And then she gives you her websites. We'll make sure that we share that with everybody afterwards. But unless there's any other questions or problems last minute, I'm going to go ahead and let you do your thing.
Awesome. Thank you. And I have an eye on the chat too. So if you feel more comfortable participants engaging via the chat, then that's totally fine as well. So I am going to be, thank you for the introduction, Kendra, and thanks for having me. I'm going to be discussing spinal CSF, which again stands for cerebrospinal fluid leaks, which cause a condition called intracranial hypotension. I'll go over some key terms if that sounds like, medicalese to you. I'll go over some definitions so we're all on the same page. Feel free to participate if you would like, and if not, no worries. I'm happy to share a link to these slides for your viewing at a later date. So definitions for those of us who are new to this topic. CSF stands for cerebrospinal fluid, and that is the fluid that is around our brain and spinal cord. The meninges refer to the layers of the tissue that cover the brain and the spinal cord. And the outermost layer of those coverings is called the dura. And the dura in Latin means tough. And so that's basically, if you've ever heard of an epidural injection in your back, the dura is kind of the barrier that holds the fluid in. I think of it as like a water balloon, basically, with the CSF being the water and the dura being that firm layer that is essentially acting as the balloon for all intents and purposes. Intracranial refers to inside of your skull, and hypotension refers to low pressure. This is a little bit different than low blood pressure. Usually some people, especially those that deal with like POTS or dysautonomia, may be familiar with hypotension from like a low pressure or a low blood pressure standpoint. When we talk about intracranial hypotension, we're referring to low pressure of spinal fluid inside of the skull. So kind of almost like a vacuum phenomenon that's occurring as the fluid is diminished inside of the skull. So I've got a little 2-minute video here just to give a really 30,000 foot overview of this topic. This won't play on your device. This will just play on the screen here. And you should be able to hear the sound. So let me know if you're not able to hear the sound.
Hi, I'm Anna. I never had headaches before, but Now I have a severe headache when I sit or stand.
Sorry, there's no closed captions, but I can drop a link to this on YouTube for those of you that would prefer closed captions.
Stand up. I have a spinal CSF leak. Let me explain. My brain and spinal cord normally float in a special fluid called CSF, short for cerebrospinal fluid. My brain really needs this fluid to function normally. When the tough layer that normally holds my CSF in has a hole in it, my fluid leaks out. Some holes are caused by a medical procedure or an injury, but mine just happened out of the blue. When I have more fluid around my brain, I feel better because my brain can float. But when my fluid is low, I feel horrible because my brain sinks down inside my head. I get a severe headache, terrible nausea, and a lot of other symptoms that are much worse when I am upright. The only thing that makes me feel better is lying down. It is really hard to work and to take care of things at home. People don't understand how disabling this is. At first, my doctors thought I had migraines because they were not familiar with spinal CSF leaks. Medications did not help. Later, they found the right diagnosis and they worked very hard with special testing to find the leak in my spine. Then they did a special procedure to stop my leak. My CSF level came back up and I feel a lot better. I got my life back. If you or someone you know has a headache that is worse when upright, ask your doctor if it could be a spinal CSF leak. This type of headache is curable. Please share this video or visit our website to learn more about spinal CSF leaks.
Awesome. Thanks for the quick rundown, Anna. So that is kind of like the 30,000 foot overview. And for those of you dealing with EDS, I know that so many of us have to kind of be like our own patient advocates. And so the reason that I'm delivering this at a level that is a little bit closer to like the level of a medical professional is because almost every EDS patient that I've ever met is essentially their own expert in EDS. Which I hope someday will get better as more and more healthcare providers learn about EDS. But in the meantime, I think arming yourself with knowledge is the best way that you can advocate for yourself. So a little bit of background on CSF. CSF kind of floats around the brain and the spinal cord, and the brain should essentially kind of float inside of the skull base. The skull base on the bottom is kind of jagged, and so we don't want the brain just resting on the skull base. We want there to be that little separation with the CSF kind of in between as a cushion. And the CSF also serves to be a cushion against any type of like impact, like a head trauma, for example, to prevent damage to the brain. Now, when we're losing fluid somewhere down here in the spine, essentially think of it like a little leak in a water balloon. And as that fluid escapes, the brain itself literally starts to drop and sag. And even though this sounds really scary, and it certainly can be, I think it's really important with CSF leaks to note that this is one of the few comorbidities of EDS that's actually 100% treatable and curable, which we unfortunately don't get to say that a lot in the EDS community or even in the chronic pain community where I've worked. So I am so grateful when we can recognize this, because once we recognize it, even though it's often misdiagnosed at onset, when we do recognize it, the treatment outcomes are generally favorable. So CSF does flow around like this around the brain. One thing that my neurosurgeon told me is that when you're thinking of the CSF, it serves to kind of rinse the metabolic waste of our cells of our brain. We've got activity going on in our brain cells all the time, and the byproducts of that cell activity creates waste products that we need that CSF to kind of rinse out after the end of the day and kind of cleanse some of the metabolic waste through a process called the glymphatic system, which stands for the glial cells, which are part of like the brain support cells, and then the lymphatic system as well. And we know that CSF basically is that rinsing agent to detoxify the metabolic waste essentially that the brain produces. And as the neurosurgeon put it, if you are not having an adequate amount of CSF that's flowing and rinsing those metabolic wastes away, then your brain is essentially sitting in dirty bathwater, which was a really, really powerful analogy. And I was like, oh, that explains why when I had a CSF leak, I felt foggy all the time and like I had essentially a perpetual hangover. So let's talk a little bit about how this even happens, right? Like, how does this even occur? So the number one most common cause, and the cause that a lot of healthcare providers are actually familiar with, is what we call iatrogenic. And iatrogenic just means healthcare providers did it. Like it was a consequence or a complication of a procedure that should not have happened. So essentially, if we do some type of epidural and the needle goes too far and it accidentally pokes this membrane, remember the dura is the name of that membrane. If we go too far and accidentally poke, then that's, you know, an unanticipated complication. And there are some procedures in which we intentionally do poke a hole in the spinal fluid membrane, aka the dura, and this is done with spinal anesthesia. And those are things like when people have labor and delivery. So it's really common for people to have this like following pregnancy, for example, where they had spinal anesthesia, or as some people call it, an epidural, but really that during a C-section, that spinal anesthesia does intentionally puncture that membrane. And so I've had several patients that had CSF leaks, and everybody had told them like, oh, you just had migraines from pregnancy. And they're like, yeah, but I never had headaches. And now I've had headaches like every day since the birth of my child, like 20 years ago. And then when you ask, you know, how was your, you know, epidural experience, they'll say, oh, you know, they let the resident practice on me a couple of times, or they had to try it 2 or 3 times for it to take. And so that reads to me someone was sticking a needle over and over again in someone's spine. And to me, that's, you know, a perfect recipe for a spinal fluid leak. The other way that this happens is via trauma. So like a car accident or what have you. And oftentimes people will recognize these because this is like a very distinct event. Like I was fine, and then the next day I wasn't. And so then a lot of times people can recognize this because they say, oh, it must have been that procedure, or it must have been that car accident. Let's investigate it. But the type that's really not very common, or rather that isn't commonly recognized, I should say, is spontaneous CSF leaks. And this can happen due to things like spinal pathologies, whether that's like calcified discs or bone spurs, or other underlying connective tissue disorders. DO stands for disorders, sorry. But other underlying connective tissue disorders like EDS. So instead of that dura being tough and really firm, just like the other tissues in our body, it tends to be a little bit softer and a little bit flimsier. And so you can either have just spontaneous like little leaks or tears that can occur in the dura when you have EDS, or in the event of having arthritis in your spine as we age, or as we have, you know, just various wear and tear on our spine, then that gets a little bit worse. And anytime that you have a soft membrane versus a jagged structure like a bone, that soft membrane is not going to win over time, right? Like that bone is always going to be, you know, the champion, if you will, and end up poking a hole in that membrane. So the picture that we're looking at right here is, this is a healthy spine on the left, and the red line is the dura. And so in a nice healthy spine, you can see these vertebral bones are like nice and square, they're smooth, and this red dura is essentially unaffected. Now on this side, this is a person who has spinal arthritis, and you can see that these bones are no longer square. They kind of start to have these little points on them, and it narrows the canal of the spinal cord. And so the dura is outlined in orange here. And so you can see there's all these little sharp areas that the dura is rubbing against. So over time, all it takes is basically like moving too quickly, plus EDS, right, or plus some underlying connective tissue disorder to kind of irritate or even tear that membrane. And someone asked in the chat, do people with Chiari who haven't been decompressed ever get CSF leaks? Yes, and in fact, Chiari is a very common misdiagnosis of CSF leaks, and we'll get to that a little bit later in the presentation, but that's an excellent question. So let's go ahead and check for understanding, and this is where you can participate on your mobile device. So which type of CSF leak is the most common? And then A would be iatrogenic or due to a medical procedure. B would be a traumatic incident, or C would be spontaneous. And you can feel free to select A, B, or C. And again, everybody's name is anonymous, so you can feel free to just put in whatever you want. And once I see that we've got at least 50% responses, then I'll go ahead and share it. So we're at about 50%. Let's give it like 5 to 10 more seconds for anybody that wants to add their answer in. Awesome. Okay, so yeah, it looks like we've got a good number. So yes, overwhelmingly, people put iatrogenic or answer A. Yes, that is the most common type of CSF leak. So due to a medical procedure or some other type of puncture. And the spontaneous leak is the most commonly misdiagnosed or the least commonly recognized, I would say. So in the EDS community, though, I would say that spontaneous is probably more common than we suspect. So thanks for participating, everybody. So let's talk and shift gears now that you've answered kind of like how these occur and how they even happened. Like what's happening when somebody has a CSF leak, right? Like how would we even know, like, could this be me? Or could this be my friend that, has, been told that it's CCI or it's Chiari or it's something else, right? Like you never know, right? And I know that when I was a patient and trying to figure out what was happening with me, that I was like, really spinning my wheels trying to figure out like, is this CCI? Is this dysautonomia? Is this just tension headaches? Like, what is this? So part of what helps is to understand like what's actually going on in the brain and causing the pain. So it's important that when we're learning about chronic pain, we understand which structures of the brain feel pain and which structures don't. So the structures in the brain that feel pain are the arteries, the veins, or what we call the venous sinuses, the dura and the associated blood vessels that feed the dura, and then the cranial nerves. And the cranial nerves are the things that allow us to smile and stick our tongue out and close our eyes tight. And they're also the things that are responsible for things like our heart rate and our balance and our hearing and our vision. So all of our like five sensory senses essentially, minus touch because that's, that's something with our motor nervous system and our sensory nervous system. But all of our other senses besides touch are controlled by the cranial nerves. So those actually can absolutely feel pain. So I know this is probably kind of hard to see, but you will all have, links to this slide if you want to review it. This is just an overview of the cranial nerves. And you may be familiar with the cranial nerves for people that have, like optic nerve issues or trigeminal neuralgia, which is where the face hurts, like along the side of the face. You might have been familiar with the vagus nerve because that controls our heart rate. But in any case, all of these cranial nerves originate at the base of the brain. So this picture, we're actually looking at from the underside of the brain. So if you were looking at me like this is kind of what you would see. So these down here is the brainstem, and all of these little yellow bunches that come off are the cranial nerves. And so you could imagine that these should normally have plenty of room to traverse under the brain and between the base of the skull. But as the brain starts to sag, what do you think happens to those nerves? And you can put in the chat or you want. But essentially, they get compressed, right? The brain literally starts to squish those nerves between the skull and the brain. And so the reason that it takes a while to kind of recognize this, because I think a lot of people think like, well, if the brain itself is like literally like starting to sag and drop, like, wouldn't you feel that, right? But part of why we don't feel this until we're starting to see those other symptoms like changes to the cranial nerves and so forth, or other types of headaches, is because the skull base and the brain tissue itself do not feel pain. They don't have the sensory organs in place to actually feel pain associated with physical changes to their structures. And that also includes the choroid plexus, which is here deep in the brain, and that's where CSF is made. And that also includes the pituitary gland, which is down here at the base of the brain. And the pituitary gland is basically like our master switch for all of our hormones. So as that gets squished, some of the other symptoms of CSF leaks that we'll talk about in a moment can really have some odd hormonal findings that are really hard to explain and that overlap with other conditions like polycystic ovarian syndrome, or as some people have heard of, like intracranial hypertension or IIH, which causes changes to the pituitary as well. So that's one of the things that kind of makes this a murky diagnosis until you really dive into the nitty gritty of like what's actually happening here. So now that we know what areas of the brain are affected, right? The cranial nerves, the lock of the spinal fluid, the arteries and veins kind of having pain sensitivity, what are some signs and symptoms that you would expect to see? And no right or wrong answer. right? It's totally up to you. You can put whatever you think you would see. So like things that the cranial nerves do are control, again, like your sense of vision, your sense of smell, your sense of taste, your hearing, your balance as well. The pituitary gland affects hormones. So anything that you'd like to put, you can go ahead and put in there. Just take your best guess at it.
Can I make one comment, a
Sure.
question, since I don't know if you'll see it in the chat? It also can affect like the ANS response to like dilating your pupils of your eyes. Am I not mistaken?
Totally. Yeah, that's
Right.
absolutely one of the
So
things
like
that we
those
can
vision,
see.
right. That was probably that, and the hormonal thing that you just mentioned, I think are so many things that are just so important. This is why it's so eye-opening when you did this the last time. It's just the things that we don't think are related or we're told are not related. It really is just really impactful.
Thanks, Kendra.
So
Yeah,
thank
no,
you.
that's a solid connection. So the vagus nerve, which controls our autonomic nervous system, like our heart rate, our sweating response, our blood pressure, that can absolutely be affected. And so I have dysautonomia that's much better now that my CSF leak has been treated. But it was so, so bad when I was sick with my CSF leak. Like I had severe POTS and really like had a hard time standing up. So yeah, I've got a lot of ones. So facial twitching, blurred pain, yeah, menstrual cycle issues. You guys are better than a lot of my like PA students and some of the PAs that I've given this topic to. So yeah, absolutely. Everything that's listed here I've seen as a side effect or a condition / symptom associated with CSF leak. So hormonal dysregulation. I just want to share this one so I can see it. It's not letting me see the whole thing. Difficulty focusing, yeah, autonomic issues, changes with the pupils and digestion, absolutely, yeah, all of those can take effect and be certainly side effects or symptoms that we see. So these are the common symptoms as listed on the spinal CSF leak websites and on some of the references and various articles that I've compiled. And those references are at the end for those of you that want to like dig into the research a little bit more. But essentially, signs and symptoms are with CSF leaks, by far and away, the number one symptom is a positional headache. So that's a headache that is worse when you're upright or worse later on in the day as you've been upright for a long time, especially if you have a slow CSF leak. And that's a little bit better when you lie down. Pain between the shoulder blades, AKA interscapular pain, changes to balance and changes to light and sound. I know that I had a lot of like sensory issues when I was really sick. I for sure had brain fog and cognitive changes. And I also had like this constant popping in my ears. Like every time I would swallow, it would like pop as if like I was in an airplane or like going up a mountain or something. Like I was having this like decompression sensation whenever I would like swallow, my ears would pop and I would get random ringing in my ears. And then also for sure I had like neck pain, dizziness, and I actually still am like trying to resolve some of the arm pain and numbness that I had. Additionally, nausea is a very common symptom because as that pituitary gets squished, that can absolutely affect some of the sensory areas that contribute to nausea in the brain. And so various other symptoms that have been reported in literature. And I just like, one aside that I want to share is that just because it's not in the literature doesn't mean that patients don't experience it, or just because somebody hasn't published an article on this yet doesn't mean that patients aren't experiencing these. So I would say a lot of the CSF leakers that I've just talked to that are other patients also experience visual changes, numbness in their face, changes in how they could taste things, and numbness in areas below the arm, like in their legs or in their abdomen, for example, depending on the level of the CSF leak. Menstrual and hormonal changes, tachycardia or fast heart rate, and then also fatigue. So I absolutely experienced all of these symptoms when I was leaking for sure. And then somebody put, can CSF leaks usually be seen on imaging or is it hit or miss? I would say generally it's hit or miss, and who it depends on is the radiologist. So the person actually looking at the film for you. And then what type of medical professional would diagnose CSF leaks? In a perfect world, that should be a neurologist, but that's you all know that we don't live in a world where we can necessarily trust every healthcare provider that we go to. So I would say the correct medical professional to diagnose it is somebody who knows about CSF leaks, whether they work in pain management or neurosurgery, or it might even be your family practice doctor, depending on who's willing to order you the imaging and who can correctly interpret it. Less common signs and symptoms. There have been case reports of people that have had this unrecognized who have literally fatal consequences. They call dysautonomia a rare complication of CSF leaks. I would say that that's probably a little bit different in the EDS population because we already struggle with dysautonomia just generally. And there have been people that have developed tics and tremors and movement disorders or other types of dementia if this is not recognized. Someone put in the chat, can you explain examples of what's included in visual changes? So that can include things like double vision. That can include changes with your ability to see things at night. So I lost my night vision when I was sick. Like I literally just like couldn't see at night. Like I would turn off the lights, for example, at nighttime to go to bed, and it was like just black, like not shadows anymore, or like, you know, where you can kind of see like the shadows of, you know, your room or whatever it is. Like it was pitch black. And so I couldn't drive at night anymore when I had this. And then I kind of started cognitively slowing down to the point where like I couldn't drive, period, at one point. So, all right. So another interactive question. CSF will follow the rules of gravity, which is why symptoms get worse as the person stays upright. So knowing this, when do you think that people are likely to experience the worst symptoms? A, in the morning, B, during sleep, C, in the afternoon, or D, no answer, like it could just happen whenever, like there's no pattern. And again, feel free to just go ahead and guess. I'll share the answers. This is just to make it a little bit less boring than sitting through an hour-long presentation, you know? Awesome, we've got a lot of participation on this. So yes, C, in the afternoon / evening, that is correct. So patients with a CSF leak tend to report that their symptoms are worse in the second half of the day or as they've been upright. So people that maybe work night shifts, for example, they might be worse in the morning if they've been like literally upright all night, for example. But essentially, the longer someone is awake and upright, that fluid is draining, and that brain is beginning to sag. So the longer somebody has been upright, the worse that their symptoms are going to get throughout the day. And that can be one of the really frustrating parts of this condition as well, because people will wake up and will be like, hey, like I'm having a pretty good day today, like I'm feeling good. And then people will start to be like, well, are you really sick then? Like you were really sick last night, and like what? You just like, you must just be tired because you slept and you feel better. And like it's so much more complex than that. So reasons that you should think about a CSF leak if you are, you know, considering this is A, if you have a connective tissue disorder like EDS or Marfan. So I would say that, you know, that these are just evidence or other symptoms of connective tissue disorders like joint hypermobility or easy bruising, et cetera. And then things that like are not just a normal headache. So like if you've been diagnosed with migraines, for example, or tension headaches, things that are not typical of migraine or tension headaches and should prompt further workup are like if you're having changes with your balance or your gait, which is like your ability to walk. If you're having cognitive changes or involvement of the cranial nerves, so vision changes, changes to your hearing, ringing in your ears, changes with your ability to like swallow correctly, like those are absolutely things that would warrant a further workup. And I put on here that the exam may be entirely normal because, as many of you know, it's unfortunately not very commonplace for healthcare providers to actually do a physical exam anymore, which is like beyond me, like why we don't touch patients anymore. But like that seems to be like unfortunately a trend in medicine. So if a patient is getting their exam at the beginning of the day, like you might go and be like pretty normal looking, and then that could be anxiety provoking because you're like, oh my gosh, like I really am sick, but like I look fine today. So like it's really hard to like get this across to people. Someone put, if you feel worse in the morning, is it unlikely to be a CSF leak? I would say that that would make it maybe move down a rank in my like list of things that it could be, but I wouldn't completely rule it out. And then somebody asked, can sleep apnea develop or worsen with CSF leak? Yes, it can. Our brain stem controls our breathing, and when that's getting compressed or sagging or stretched, then that can absolutely change, our ability to breathe, especially when we're not consciously breathing throughout the day, especially like at night, for example. So clinical mimics, what that means is like, what else does this look like in a clinical setting? I've seen patients diagnosed with dementia or Alzheimer's disease. That's what AD stands for, or Alzheimer's dementia. I've seen Parkinson disorder because tics and tremors can develop, especially as the cerebellum, which is our movement center, gets irritated with that drop in the brain itself. I've seen this misdiagnosed as migraines, misdiagnosed as POTS. But what do you all think? What do you think are some things that this is probably misdiagnosed as? And unfortunately, right now, the average time to diagnosis is like 10 years plus. So that's a lot of trips to a lot of different doctors over a lot of time. As Kendra mentioned, like I am a healthcare provider. I work with neurologists, neurosurgeons, and pain management specialists. Like that's my niche. And it still took me 3 years to get diagnosed and like 15 different doctors. So
I keep thinking of dysautonomia. I mean, here I'm an EDS patient too, and I know so many people, and even in the EDS community, how many are told that they don't have, not to have, or not, this shouldn't be considered because they don't have, the worsening headache, the headache every day. It's like they have the gradual symptoms, like you talked about, the things that are slow. I don't think that's discussed enough. And
I agree.
I mean, how many of us, dysautonomia, I mean, I could go on, have these weird other things that nobody can explain and they don't know, and they just said it's part of EDS. I'm interested to see what everybody else says too.
Yeah, no, I definitely see some common ones in here that it can be misdiagnosed as like stress or tension headache or like some type of psychosomatic disorder. I see vertigo in the chat, dysautonomia, anxiety, migraines, for sure. Like these are all things that I've seen. Theoretically CCI or Chiari, those are actually very common overlaps. And I can say that just because somebody has a CSF leak doesn't mean they don't also have like dysautonomia plus CCI. But I think that it's worthwhile to kind of consider CSF leak, and we'll talk about why when we get to the treatment. PCOS, fibromyalgia, radiculopathy, all of these are actually like spot on with some of the things. And unfortunately, anxiety and somatic disorder are like very common misdiagnoses. The last neurosurgeon I went to before, or the second to last neurosurgeon I went to before I found like the person who took it seriously at Cedars-Sinai, told me that I needed to get a massage, but not on my neck, LOL, because I was in a neck brace. And he like literally just laughed about it and was like, just get a massage, hun. Oh, haha, not on your neck. And I was like, thanks. Like, yeah, because I came here like, because I just needed a massage, like, okay. And then the last neurosurgeon that I saw, when I literally took her like peer-reviewed literature on EDS and CSF leaks, like printed in my hand 2 articles for her to review, she told me that what I thought I had wasn't real and that I had a somatoform disorder, which basically means like I was making it up. So, and this was a colleague of mine. So, it's definitely, all of these are like common misdiagnoses. So key points to take away when we're talking about like sorting through the murkiness of this diagnosis, is that the headache might not be the most prominent symptom, right? Like everybody wants to say like, oh, the positional headache, like this person doesn't have positional headache, or maybe it's not getting better when they lie down. So like it can't be a CSF leak. But like you said, Kendra, like if you have this for a long period of time, actually the longer you have this, the less prominent that positional headache is. So I know that I had second half of the day headaches where I just thought like, oh, I'm fatigued, I just need to drink more coffee like halfway through clinic.
Or especially if you have a bunch of different types of headaches and you've had them, growing up, and you've just been migraines, whatever it is, and you're told it's just part of.
Absolutely. And also like when you consider like the other symptoms that we've mentioned, like Headache for sure was like not even on my top 5. Like my top 5 symptoms were like, hey, I haven't had a period in 6 months. What's happening? I gained 40 pounds in 2 months, 3 months. What's
I can't
happening?
believe you just said that.
Okay.
That was one of my questions, was the weight gain. Like, wow.
Yeah, I had a massive weight gain in like a couple of months. And then I also was super brain foggy. I couldn't see at night, right? And I was getting like ringing in my ears. So those were like way more concerning to me than a headache, right? And then followed by like the POTS and the dizziness. So like that, it wouldn't even made like probably my top 10 list, because I've always had headaches and neck pain to some degree. So just because the headache isn't like the primary thing doesn't mean that this isn't happening. And it's also important to point out that like this can be very disabling, and it's often underappreciated because sometimes it's better and sometimes it's worse. So it kind of has this like up and down kind of trajectory. And it's important to note that like there are profound complications if we don't catch this. And I'll show you a video at the end that kind of demonstrates what I'm talking about. But this is curable. Like this is literally like I'm talking with an injection. Like most people don't need surgery or invasive procedures to treat this and cure this and have like significant relief. And then somebody put, is it possible for CSF headaches to be controlled with traditional migraine meds? Yes, it can be, especially if those migraine meds have caffeine. Caffeine is one of the things that raises spinal fluid pressure. So anything that raises your CSF pressure actually probably helps in some cases. Medicines that are used to treat migraines that typically make this worse are things like Topamax, aka topiramate, because that is in the category of drugs that actually lowers the CSF pressure. So people that have taken Topamax or Diamox and gotten way worse, this would be something that I would consider, because those meds lower the CSF pressure. And so if you're symptomatic and that med makes you more symptomatic because it's lowering your CSF pressure, then that would be certainly something that I would consider.
What about stimulants for like ADD focus? Would they help?
For some people, they do, just because the fatigue and the brain fog can alleviate with that. And that can also increase the blood pressure to the brain because it's a vasoconstrictor. So for some people, it can help to some degree. But you know, just as an aside. Okay, so let's talk about the workup, right? Like, so people that are like, okay, what do I do now, right? Like, you know, I might have this, or I might know somebody that has it. Like, how do I even like begin to get started, right? So 80% of the time, you can catch this on a traditional brain MRI. In a perfect world, we want it with and without contrast, but we can see it on a brain MRI. And I've actually got some examples here so that you can see like just how profound the differences are versus a normal brain. The really big caveat to that is if you have a radiologist who like basically isn't trained to read these, then they may miss it. I got read as a normal brain MRI for 3 years, and it wasn't until I taught myself how to read my own imaging that I was like, oh, like I've had a CSF leak for 3 years. Like this would have been really, really helpful. So 80% of the time we can catch it on a CSF, or excuse me, on a brain MRI. Not necessarily with contrast, especially if you're really sensitive to contrast, then just do a non-contrast. And then only about 50% of the time will we catch it on a spinal MRI. And a lot of the times we need to get what's called a myelogram, which depending on the area that you live in, will either be a CT or an MRI, and may or may not involve a puncture in your back, which is something that I would highly recommend deferring to one of the specialty centers in the US, because you don't want to just go and do this at like a community center in like a rural part of whatever state that you live in. You for sure would want to do this like at a specialty center. Okay, so brain imaging. Let me see. Sorry, just really quick, someone put it in the chat. If just to clarify, if Topamax made you way worse and gained 30 pounds, is this a red flag? I would think of it as a drop in, like kind of like a point towards CSF leak. I wouldn't say that that's like the thing to hang your hat on, but like to me, that would make me think like, oh, that would like raise the suspicion that I have for this diagnosis if somebody got worse with Topamax. So, but difficulty word finding and difficulty with like cognition that doesn't resolve after taking Topamax is unusual. Some people report like worse brain fog and stuff while they're on Topamax, One of the docs that I worked with actually calls it Dopamax because he says that a lot of people get like worse, like cognitive issues with it. So if that doesn't go away after you take it, then yeah, I would certainly like talk to your prescriber about that for sure. So here's the common findings on about 80% of people with CSF leaks. The mnemonic is SEEPs, and I'll explain what all of these are when we get to the picture, because I know that some of these probably sound like medicalese, but bear with me and I'll show you pictures of it. So subdural fluid collections are fluid below the dura on the brain itself. Enhancement of the meninges, so like the linings of the brain look really enhanced and bright. Enlargement or engorgement of the venous structures, so the veins look really dilated in comparison to what they normally would look like. Pituitary hyperemia, which means basically an enlarged pituitary, and then sagging of the brain itself. So let's take a look at what that means. So when you're looking on here, this is a person with CSF leak, and you can see these are just different ways that they weighted the same brain. So this is all the same brain, basically. And so you can see on here that this person has this big like fluid collection right here, where like their brain stops here, and then between their brain and their skull, there's just big, like massive fluid, basically. So that's a subdural fluid collection. You can also see that this person's pituitary gland is pretty large in comparison, and that the brain is kind of like draped over it rather than sitting above it. So this pituitary is large. You can also see that the meninges are enhanced, and I'll show you that on a different picture. But then there's also engorgement of the veins. So this is like the best vein to look at, which is the transverse sinus in the back of the brain right here. And normally it kind of has like a kind of a convex, a concave kind of shape. So instead of being like a perfect circle, it kind of looks like this. The brain normally takes up space on it, and it kind of has like a little concave section to it. So if that transverse sinus is really nice and plump and round, that certainly would be like an engorged vein. And then actual sagging of the brain. And someone asked in the chat, how would you ever tell the difference between, or does anyone ever tell the difference between this and Chiari? And the sad answer is that sometimes they don't. I actually have a very dear friend who was misdiagnosed with Chiari and had 2 decompression surgeries, even though it was a CSF leak the whole time. So that is like just absolutely like should never, ever, ever happen. Like that was somebody that just didn't know about CSF leaks and basically was like, this is Chiari. The ways that we can tell is that this little section right here of the brain called the pons, this essentially this little part right here should be somewhat rounded. So instead of looking really flat, how this does, this little part of the brain should be kind of round, like a little belly. To me, it looks like a little cross section of like a seahorse or something, where like this is its head and this is its tail. It should have a belly on it, and it should be round. So if it looks really flat like this, that's not just sagging of the cerebellar tonsils, which is this area that we see in Chiari. So in Chiari, we only see descent of this part of the brain, not the whole brain itself. So that's the big difference, is that in Chiari, it's just this part of the brain that's sagging, the cerebellar tonsils, versus with CSF leak, it's literally the whole brain. So it's the pons, it's the midbrain, AKA like this little area right here, and this area as well. And it's also some of the structures. There's various like other imaging measurements that you can do. But if you feel like, I don't think this is Chiari, it's certainly reasonable to get like a reread or like ask them to read for a CSF leak and get it sent back to the radiologist to look it up, or send your films to one of the specialty centers that knows how to do this, because unfortunately my friend who has had this done has had profound complications because she had like essentially surgery that was inappropriate. And it's totally like not okay that happens. So that's part of the reason why I try to educate everybody about this, because I'm like, it might not be Chiari, and like that's a major invasive surgery, and the treatment for this is literally an injection in most cases. So even if you're not sure, and even if you were like, I'm 50% certain it's Chiari and I'm 50% sure it's a leak, like the treatment for a leak is super like relatively non-invasive compared to like decompressing your skull, so it's, certainly a better, that would be my route to go, is I would go with the least invasive first. And then someone also asked, can this be seen on a regular MRI if done horizontal? Yes, it can. So it doesn't necessarily need to be upright. And also just a note on upright imaging, the image quality on upright MRIs are terrible, like literally almost illegible. And usually being in an upright MRI, especially if you're getting like the flexion extension MRI, will probably trigger your symptoms and flare you up because you're literally holding your head in like extension for 40 minutes and then flexion for 40 minutes and then upright for 40 minutes. And if you're symptomatic, try doing that without like moving or twitching or jerking, like it's almost impossible. So the image quality comes out like really poor. So if you're like, hey, there's no way I can do that, like just get a horizontal image. It's totally fine. This is an example of enhancement of the meninges, where you can see like the covering of the brain is very, very bright compared to like the dark part of the brain here. And then also, again, where these arrows are pointing, how this little part of the brain is kind of like a straight line instead of round, how it should be. All right, so for those of you who are participating, this is like an actual drawing of comparing like a regular brain versus a CSF leak brain. So on the right-hand side is a normal brain, and on the left-hand side is a CSF leak brain. And while you are doing that, I'm gonna switch my camera and actually step outside because my husband's got work that's gonna be starting for his office hours. So I'm gonna have a change of scenery, but while you're at it, just go ahead and take a moment, or while I'm doing that rather, take a moment and go ahead and draw any differences that you see, and I'll be right back.
All right, I'm not participating in the actual thing.
That's okay.
kinda
But
wish
do you
I
see any
was.
difference? You can like verbally see it or say it out loud if you want to. But
This is crazy.
because like it looks
It's,
totally different, right? Like I know that no one here is a radiologist, but like when I look at these brains, I'm like, those are not like even close to the
yeah, it
same.
looks normal.
Yeah, over here is normal, but then like over here you can see like there's kind of changes, like there's
I
like
see
almost
more,
like the brain
yeah,
doesn't fill up as much, you know what I mean?
right. Or there's less like, I don't know. That's crazy.
Yeah. Yeah,
How
it's like
often is,
squashing. Exactly.
it makes you think about all, there's so many questions. I mean,
I
how
know.
many of us are, the
I
last
know.
time you did this, I felt the same way, and I'm even more
I know. It's like one of those ones
just,
where it's like, oh God. So yeah, somebody
yeah,
submitted here. Yeah, so you could totally see there's like less volume here. It's more flat here. Those cerebellar tonsils are totally like descending. And then this part of the brain, like the corpus callosum, is kind of like, it looks like somebody took it and went like that to it. Like they just kind of like squashed
yeah.
it. Yeah,
That's what
I
somebody
see in the
said.
chat, the
Brain
brain
looks
looks
smashed.
smashed. Yeah, or squashing. Yeah, I agree.
I
And
wouldn't
then
have noticed
someone,
that right away. Yeah, it's
right.
crazy.
And so here's a good one. We see this little concavity right here in that vessel versus this one is big and round. And then also those cerebellar
Wow.
tonsils for sure. And then let's see if we have any other ones. Somebody put that back here. Yes, they've got like changes. Down here is the sinuses, but good catch on like noticing that those are different. And then they also pointed to like this cerebellar area. And I'll point out a couple different things. Thanks, babe. David's actually doing his office hours outside, so I could just stay set up in here. So differences that I note as well that I didn't see annotated is the angle here. That's called the VGSS angle. It's the vein of Galen and the straight sinus. So this is the straight sinus, and this is the vein of Galen. If you look at the difference of these, what is the difference on those angles? So the CSF leak brain, that angle is more acute. It should be kind of closer to anywhere between 60 and 90 degrees, but as that gets closer to like a 45-degree angle, that means the whole brain itself is literally like just starting to sag. Yeah, one is like 90 degrees on the normal brain, and then this one is like, certainly a little bit more acute of an angle. And so I'll erase it so you can kind of see it there, but that angle is like acute. And then definitely there's the flattening of the pons on this brain, which is this little guy right here. And then one last thing that I want to point out is the space between the top of the pons and the mammillary body, which is this little, like, I think of it as like the arm of the seahorse, because I literally like see a little seahorse like this when I look at the pons, like its little head and its tail and its belly and its little T-Rex arms right there. But if you look at the space between them, see on the CSF leak brain, the mammillary body and the top of the pons are like almost touching. And then over here, there's plenty of space. So the CSF can kind of like float through it. So that's another one of the measurements. So if you're looking at 100 brains all day as a radiologist and your primary care, the person who ordered this, like didn't really give any context, right? If they're just like brain MRI, then like, I don't blame a radiologist who's looking at 50 of these a day or 100 of these a day for just being like, like I don't see a mass or a tumor, like I guess that looks normal. So the way
Or they're
that you
ruling out an aneurysm too.
exactly, they're looking
right?
for like stroke, aneurysm, tumor, those kind of things. If they don't see those things, then they're just going to be like, yeah, it looks normal. So what you can have your healthcare provider, whoever's going to order you this image, ask them to put on the order, please read for spinal fluid leak, or please read for intracranial hypotension. And chances are the radiologist will be like, wait, I don't even know how to do that. And then they're going to have to Google it real quick. And then they'll find like the answers to this, because what we're covering should take a radiologist like 5 extra minutes out of their day. Like it really shouldn't be like a huge ask. So you can ask your healthcare provider to write on the order, please work up or rule out spinal fluid leak or signs of intracranial hypotension. Okay, so let's close this up. All right, thanks for everybody's participation. Appreciate it. Okay, so kind of switching gears now that we've gone over brain MRIs, we're going to move into spinal MRIs. And so we have about 10 slides left after this for those of you that like are, kind of on the struggle bus. So I'll try to like move a little quicker so that we could leave time for questions. So something to think about is that the dura itself is not just like this nice, perfect tube. Like even in PA school, the only images of the dura that I saw were like this up in the corner, where it's like the perfect like tube that covers the spinal cord. But in reality, the dura is actually like almost like a jacket. Like if you picture your spinal cord as like a centipede, basically wearing a jacket, the dura is like a jacket. And so each of the exiting nerve roots, you can actually have little collections of fluid on those exiting nerve roots. So the spinal fluid leak might not always be right in the center. It might be off to the side on one of these little arms. And if you're having trouble conceptualizing that, pretend like my body is the spinal cord and my arms are the nerve roots. Sometimes the sleeve itself gets stretched out, and that's where the spinal fluid leak is. So it's off to the side on one of the arms, so to speak. So on the workup of this for spinal imaging, please know that if you get like a non-contrast MRI of your spine ordered, they're probably not going to pick it up. It's often necessary to repeat it with contrast because you're really having to contrast the fluid and find like, okay, like where is this fluid even going? So sometimes you may need to get a CT myelogram or an MRI myelogram. And sometimes in the workup, they'll even order a lumbar puncture. And if you're going to need to get a lumbar puncture, that's essentially like they're poking a hole on purpose. So the way that you can advocate for yourself is to ask them to measure what's called your opening pressure on the like onset of that puncture, essentially. So the opening pressure, and basically that's going to be when they go in, they're literally just going to say like, what was the pressure of your spinal fluid? Kind of like checking the pressure of a tire, but like it's your spinal fluid, right? So you want to measure the opening pressure, because if you're going to get a poke in your back either way, you want to make sure that you like are getting as much data as you can out of one poke rather than having to go back and do that. So a normal pressure, the literature varies, but it should be between like 20 and 60 millimeters of water. That's how they measure it, instead of millimeters of mercury. So if you're like below 20, that would certainly be an indicator that you're low on your CSF. Mine was 12 when they did it. So they were like, yeah, that's like slam dunk a leak somewhere, basically. And so this image right here was done at Cedars-Sinai. This is actually my spinal MRI. So for those of you that are like, well, she didn't do a good job like shielding the patient information, it's my information, so it's like not a HIPAA violation. But this was with contrast on the MRI, but the radiologist didn't pick it up. But this right here where the arrows are pointing is literally like spinal fluid trailing out of my spine that they picked up on MRI, and the radiologist was like, normal spine. So it took me reading my own films to be like, no, not normal spine, sir. Like I'd like a reread. And he was like, I don't know what that is. I literally called because at the bottom of your MRI report, it'll say like, if you would like to speak with the person who read this image, like they put their phone number on there, they have to by law. And so you can actually call and be like, hey, like I'm looking at image number, whatever, like that'll be up in the left-hand corner usually. And that doesn't look normal to me. Can you like tell me what that is? Or can you like tell me, you know, can you read that to me or whatever? And sometimes they'll reread it. And in this case, the radiologist was like, I don't know what that is. I've never seen that before. And I was like, so why did you call it a normal? It's fine. Ugh. But anyway, when I went to Cedars-Sinai, they did this image called an MR myelogram. So this is an MRI myelogram with IV contrast. So I didn't need to get poked in the back for this image. And you can see all of these little like bubbles on the side right here. And those were all CSF leaks. So this only goes up to this level, but I have 2 up here and then 1 on the left up here. So I have leaks from T9 to T12. This big guy right here actually had a vein that had grown to it. And so I needed surgery for that. But in many cases, this condition is treatable with an injection. So let's talk about the treatment. So that part of the spine, that was my lumbar or my thoracolumbar spine. So it basically is like the small of my waist, basically like right kind of in the center of my back. So there's treatments that range from conservative to surgical with this illness. And some of these things can actually help you determine, do I have a CSF leak, right? Like, or you know, should I really consider this as like something that I can have with some of these conservative treatments that aren't harmful and that you can kind of try yourself. So conservative things are like bed rest and fluids. For some people, as long as it doesn't exacerbate your POTS, caffeine is relatively low risk. But if those things help you, if lying flat, if fluids and caffeine are helpful for you, then those are indicators that you have low CSF pressure. Another really common thing is an abdominal binder. So I'm not talking like compression socks. I'm talking like either a back brace or an abdominal binder that literally goes like around your whole abdomen. For me, I like to wear like my compression shorts or like Spanx because they go up like to right under like your like chest area basically and provide enough compression that I feel like everything's just kind of like smooshed up. And the reason that that works is because remember, we're talking about like a water balloon basically. So if you squeeze the bottom, then the fluid goes up to the top. So I wear like Spanx basically every day and it helps me feel better because that compression keeps more like fluid in my brain basically. And there's also complementary and alternative therapies. CAM is the like other like term for that. Certain vitamins and so forth have been recommended by the Spinal CSF Leak Foundation. If you go on YouTube, there's a whole like holistic management of CSF leak, you know, video on the Spinal CSF Leak channel. The mainstay of treatment though is an epidural blood patch, and I'll show a picture of what that looks like in the next slide. But it literally is exactly what it sounds like you are putting a patch there in the epidural space of your own blood, like fix a flat, but with your blood basically. If that doesn't hold, they can then up the ante and use glue. Yes, like glue in your spine. And then if it's really severe or you're not responding to patches, then that is something that may potentially require surgical intervention. Okay, so before we move on, I just want to answer some questions. So somebody put, it's interesting that research shows that wearing abdominal compression is also effective for POTS. I wonder how many have CSF leaks. Me too, Megan. Me too. Like I absolutely wonder that all the time. That's like one of the things that like keeps me up at night is like, how many leakers are we missing? And I like call Kendra and I'm like, let me like steal an hour of your time so I can tell people about this. But yeah, I get really like hyped about it. And then somebody asked, is having only unilateral hyperreflexia, a sign of CSF leak or more so AAI, CI? I think that can occur with both. I had hyperreflexia pretty much on my entire left side, and I still have neurologic deficits on my entire left side as a result of my CSF leak. But I also have CCI that got way worse when I was leaking. So once I fixed my leak, my CCI got a lot better too, which was awesome. So here's a picture of an epidural blood patch. So they go in with a needle and they draw your blood first, basically, and then they take that blood and inject it into your back. The doctor that, or the type of doctor that I would recommend is a pain management doctor that can do this because they literally do epidurals like their bread and butter, like all day, every day they're doing epidurals. Whereas if you go to like a big specialty center, they'll have somebody called an interventional radiologist do that. And sometimes they don't do epidural blood patches all day long. They do like cardiac catheterizations and a whole bunch of other procedures, which is awesome. But blood patches are not like their bread and butter. Whereas like if you go to a pain management doctor and you have a really solid relationship with your pain management doctor, you could actually ask them for a blood patch if they agree that this is like likely something that you could have. And we'll go over the treatment algorithm in a second. And more the literature is saying before you go through this big old workup, before you get contrast injected in you and get your whole spine MRI'd and spend thousands of dollars on imaging, try a blood patch. Your pain management doctor can do that with no problem. They cover it with insurance. There's a diagnosis code for a leak headache. So like the new treatment recommendations are actually like to try a blood patch and see if it helps. So somebody asked, could a caudal steroid epidural steroid injection for a lumbar degenerative disc disease make this worse? Potentially, if you do them chronically, because steroids over time thin tissues out. So if you're getting like repeated steroid injections around your dura, it is going to thin your dura out over time. Okay, and then here's a picture of what surgery looks like. So if somebody like had a big old leak, basically, then they can go in and suture it back together. Again, not super common to need surgery for this. How does one determine where to apply the blood patch? If you've got something on imaging, you can do it there, but in general, they can target it at what they call the thoracolumbar junction, which is basically like the T12L1 area. And I know this is like a super tiny slide, so I'll just kind of give you the gist of it. On the left side, this is the criteria to diagnose the headache of CSF leak. So if you basically have a leak or one of the following, which is like low spinal fluid pressure on the lumbar puncture, or evidence of leak on neuroimaging, and you don't have another thing that explains it better. Like your neurologist is like, this isn't a migraine, this isn't a cluster headache. Like I don't have any other possible explanation for this other than a leak. Dr. Shavink, who's at Cedars-Sinai, created his own criteria because he's like literally the world leader on this. And he's in Los Angeles. So sorry, that's like the one specialist that we get on the West Coast is Dr. Shavink. The CSF league people are on the West Coast. I feel like the East Coast people get like a lot of the good specialists for everything else. So we have some experts out here on the West Coast, and then you all have the experts at Duke in South Carolina, I want to say is where Duke is at.
North Carolina.
North
Yeah.
Carolina.
That's what I was just saying to Liz. I was saying, I think from what I remember, it was California and Duke. And it was pretty, you know, in terms of specialists and who really are the best place to go.
Yeah, fair. Yeah, they're wonderful. They're also very, very compassionate. Like the video that I'll show you at the end is from Duke. But so the Shavink criteria is if you have an orthostatic headache with low opening pressure, or those little, they call it meningeal diverticulum, which, just to refresh your memory, are like these little guys back here, like the little bubbles of CSF on your spine. Or if you have improvement after a patch. So literally, like if you have an orthostatic headache and improvement after a patch, then you have a leak. Basically, that's how they're categorizing it now. On the treatment algorithm, this is usually for healthcare providers, but you can use this to give to your healthcare providers, and the link for this is in the references as well. Basically, if you get an MRI with and without contrast, and there's even anything that's suspicious for a leak, the next step is to try a patch, right? That's pretty simple. So literally just try a patch. And they said that you can do a 2-level non-targeted blood patch. So a lot of pain management doctors, especially if they've never done this before, they'll be more comfortable doing like maybe a 1-level patch. And they usually say do it at like T12L1. So yes, to answer your question, you could get a patch without knowing where the leak is. And if it helps you, then you know you're on the right track. And then that can allow your insurance to let you like go to some of these like specialty centers like Duke or like Cedars-Sinai, for example, and get further, further evaluation. Okay, so key points and takeaways, and I'll get to a couple of the questions in the chat after this, is that there's kind of an unknown percentage of patients who kind of self-seal, like their symptoms go away after a period of rest, and we don't really like know how many of those patients there are. That sometimes this disease can cause like serious, profound like coma or bleeding in the brain. But it's really important to note that for a lot of people, once you get the correct diagnosis, like the outcomes are very favorable generally, but the longer you wait, the longer or the higher the likelihood is that you might have some long-term consequences. So like for me, I went 3 years without knowing what this was, and I went to like 15 different doctors, and 14 of them told me I was crazy, basically. And I still I went to a new neurologist yesterday, who basically was like, yeah, you still have like deficits on like your entire left side. So they're ordering like new, workup for that and, treatment for that. And this is 3 years later, basically after I got treatment and, had successful outcomes and have been able to return to work. So the sooner you get this addressed, the better. And it's also important to note that even though patches are effective, just because you get one patch doesn't mean you're going to be like cured forever. I have had over 20 procedures in the course of my treatment, but I also have 5 CSF leaks. So like the fact that I have many leaks in many different locations has complicated the treatment process. And then also I have EDS, like that's another complicating factor to this, So, but overall, most patients do well. It depends on, again, like your comorbidities or how long your symptoms have been lasting. But essentially, like the thing that really drives me to be like, go get this evaluated is that long term, if you don't get this treated, it's starting to show more and more like literature to support the fact that your brain is essentially being re-injured, right? Like we talked about at the beginning of the episode that your brain is like sitting in its own dirty bathwater if you don't have enough CSF. And that's not good for your brain, right? Like your brain, it needs to be cleaned and rinsed of its metabolic waste. And cognitive deficits can accumulate and stack. And there are people that have had early dementia as a result of an untreated leak. So it's really important to get it evaluated and treated. And so this video, and I promise I'll answer the questions after this video because this is like the end of the presentation, but I show this video because some of you might recognize yourself or a loved one in this video. And I think that after talking about like serious complications and stuff, that it's important to leave you all with like a positive note so that you know that this is treatable and that there is hope for you if you think that, hey, this maybe is me, right? Like I think it's important to know that it doesn't have to be like a doom and gloom sentence, right? So I'll go ahead and play it here.
It's okay. You're gonna be okay again.
Oh, I don't think I'll ever be okay.
Yeah, you will, Dad.
Your dad is your first hero. You think he's so strong that he could do anything. I know he was everything to me. He always had my back. And I knew I needed to have his now. You just know when something doesn't feel right. I had 17 neurologists, 9 neurosurgeons all tell me that I needed to stop being in denial and accept that my dad had late-stage dementia, if not Alzheimer's. Things got way worse. He lost all control of all of his bodily functions, could no longer walk, could barely speak. He didn't even know he was on this planet. It was utterly terrifying.
This procedure has brought me back from very, very deep depths of darkness. And I knew all of a sudden you're back. And you feel like you. The miracle of the procedure at Duke has finally given me back myself. I can be me. I can be a father. I can be a grandfather. I can have interests. It's been wonderful. It's given me my life back.
That one always gets me. Like I seriously tear up every time I see that. Like it just
Really, I'm with you.
Yeah, it's so profound, and like that really just shows like the power of advocacy. And that healthcare team is the Duke Care team with Dr. Linda Gray as the head of that team. They have amazing neuroradiologists. They take consults, like of rereads and MRIs and so forth. And they are absolutely like the pioneers of the non-invasive and non-surgical, like treatment of this disorder.
And how many
So,
older people would just be thrown to the side? Even like, I think of my dad this summer, and he had this like significant cognitive just shift. And I remember thinking, what is going on?
mhm.
But how many times does that just,
Right, like
dismissed as dementia or
seriously,
Alzheimer's, but it's sudden and but they're older and they're 80, like it's just, but they're not able to live their life like they were.
right.
I mean,
No,
that's just an
100%.
amazing video.
Awesome.
Thank
Okay,
you for
well,
sharing that.
no problem. I feel like we
Now
needed
that we're
like
all
a pick
crying,
me up. I know, seriously, like some happy
but that's
tears, right?
amazing.
Um,
It's just amazing.
yeah, I mean, it totally is. And for those of you that are participating on the interactive piece, if you have any final thoughts, feel free to put them on there, because I love your feedback. If you're like, hey, this was too long, or it was too like at a medical level and I would like something that's like more at patient level in the future, like I would love to hear your feedback, because I want to make this the most informative presentation for my audience, right? Like whoever is listening, I want it to be the most effective and engaging, so that it's not like, a bore to be basically. But I'll go ahead and answer the remaining questions in the chat, and then I'll stop sharing my screen and we can go ahead and like answer any other questions that are out there. So let's see. Somebody asked about like the bubbles on the image. What type of MRI was that? That was called an MR myelogram, and that was done at Cedars-Sinai. So that probably is something that you're not going to have access to like in a community center. That usually needs to be done like in like a tertiary care center, meaning like a big university hospital, basically. And then somebody asked, if you hate having compression on your stomach, could you have intracranial hypertension? That is certainly possible, because usually people that have low pressure really like having compression on. And a myelogram just refers to imaging of like the spine and spinal cord and spinal fluid. And so it's basically just like a very detailed image of like the neurologic structures of the spine. So only like the CSF and the meninges and the cord, rather than like the bones of the spine as well. And thanks for the feedback on the
I love the
earpod.
interactive portion. I would love to
Thanks.
dive more deeper. I think it brings up so many questions for so many of us. And I know that you've done different webinars for me on different topics too. And every time Briana does a webinar or has presented on many different things, she's always so amazing. And that's why I love bringing her to speak to everybody, because the information that she can provide is so, so helpful. And she's also amazing at delivering it.
Thanks. That's so nice of you, Kendra. I really appreciate that. And
Well,
thanks
I
for
love
the
you. As
positive.
a friend and as a professional, I
Same.
mean, I just think this is
All
so
right, back at
helpful
you.
for so many of us. And it
Thank
just helps
you.
us understand it. Let's see if there's more questions. I actually wrote down a couple extra if people didn't have it. I
Awesome.
think you answered most of them.
I have one in here that was in the like final thoughts, and somebody put like they had to essentially like stop doing like their somebody is a PT rather. They had to stop practicing due to CCI and related issues, and this is something to explore before fusion. And so just a note on that, because like it is really hard to differentiate this condition from CCI, from Chiari, from dysautonomia and so forth, right? And so for me, I look at it like in a couple of ways, right? Like, is there something that you can treat? If yes, you should try to do it if it's not going to like upend your life and cause like permanent irreversible consequences. So one of my very best friends, and I'm actually going to be bringing her on as a partner in my small business, which I had to step away from because I was sharing with Kendra, I was in a job situation that was like not disability friendly basically, but now I'm with a new employer and I have time to dedicate to my small business, which is where I work as like a consultant and a patient advocate, essentially to help people, to help answer some of the questions that you might have The way my business is set up is I don't offer medical care at this time, but I hope to, hopefully in the new year, be able to like see patients again, because in California, physician assistants can like go across state lines if they're certified in like respective states and offer like medical care. So, but I would love to, you know, if you have questions, I do free 15-minute phone calls because I don't want cost to be a barrier to people who can't access, you know, a more extensive call with me. And then my email address and website, I'll go ahead and put in the chat. But I just wanted to share that like one of my best friends is basically one of the ways that we met was through Facebook. She lived in the same city as me and was like, hey, can we just get coffee? I have questions about this. Like, you know, I'm literally going to go get my
That would be
spine.
me.
Yeah.
I would totally have done that if I was close to it.
Hey, no shame in that game. Yeah, no
Right.
shame in the game for sure. I feel like Facebook is like, you know, has for all of its quirks, you know, has its utility for sure. But she connected with me on Facebook and was like, hey, can I buy you a coffee? And like, can you tell me about this? Because I'm literally about to fly across the country and get my cervical spine fused because, you know, I've been told that this is the driver of all of my symptoms. And I was like, hey, think about a CSF leak because if you get your spine fused, there's no going back. Like you don't like, you know, like the fusion doesn't absorb and like you return to like a normal state, right? Like it's not helping your body heal. Like you're literally getting like a permanent thing done to your spine basically. And with EDSers, and with even just the like normal and healthy population, I use air quotes because like normal is like very ableist in my opinion, but like in like healthy individuals that get spinal fusions, the next level of their spine starts to break down because it's compensating for that movement. It's called adjacent segment dysfunction. And literally every pain doctor that I've worked for is like, thank God for fusions because they keep us in business and keep people on chronic opioids the rest of their lives, which I'm like, that is sick and twisted and also true. So
yeah,
basically,
and I'm so glad you brought that up because it is, and it makes you kind of feel sick to your stomach, but it's so true when you just look at the pure biomechanics of the body and what happens, and especially if you're hypermobile, it just makes me very sad.
right.
And
yes, it is
yeah.
really sad. And like that, I told that to my friend and basically was like, look, like if you get a blood patch, right? The worst thing that's going to happen is that you might have a worse headache for a couple of days if it's not the right treatment for you, right? Best case scenario, you're going to get a patch and it's going to help you. But either way, this is not a permanent intervention, right? Like think of it as like a, both diagnostic and therapeutic. Like it's giving you data, if nothing else. And there's a large percent of a chance that it will give you relief. And so she went ahead and just got a blood patch, and that was it. That was what she had, was a CSF leak. And she still to this day has not gotten her spine fused because she doesn't need it. Like her CCI got better, and she also has EDS and POTS and the whole nine, because she had a leak and she got a blood patch.
Well, and she probably
So
felt
she's
better,
better.
so then she could do more and strengthen more and just do more even during the
Yes.
day, which helps strengthen just in general.
Yes. And so somebody asked in the chat, like, what is adjacent segment? So the adjacent segment means like, oh, I actually have my little spine model right here. Let me grab it. Oh, I'm so happy that this came in handy. Woo. All right. So the adjacent segment is like, let's say you fused these two vertebrae together, like the L4 and the L5. And now instead of them moving naturally how they should, they're stuck together. So that means that the segment next to it, which is L3, L4, is going to compensate and move more because these are stuck as a unit. So even in like a healthy individual who doesn't have EDS, I should say a non-EDS individual with like typical connective tissue, they will develop adjacent segment instability over time because that piece next to it is essentially making up the mobility that you're losing to a fusion, essentially. And so somebody put that they had, you know, a pelvic fusion and then had issues at L4-5. So yeah, that's very common. So to me, it's like, okay, if you're going to get your neck fused, right? Like A, that's irreversible. B, that's going to be additional problems probably down the line in like, you know, 10 to 15 years that you might have to have repeat surgery. And like getting a blood patch is, in my opinion, a lot easier. It's much safer and less invasive than getting a fusion. And like I said, like if anything and you get the patch and it doesn't help you, then you can say like, okay, I know I don't have a leak. Like now I can say with 100% certainty, like I'll move forward with like the Chiari surgery or with, you know, the CCI, especially if it's just kind of murky, right? Like at some point, we were considering a fusion for me. And I was like, yeah, there's no way, like, unless I'm literally like bed bound, then I'm not doing that. You know what I mean? And so, you know, fortunately for me, the leak was what it was. I was able to get access to treatment. I'm very lucky that I live like an hour and a half away from Cedars-Sinai in Los Angeles. So I can get there and get treatment and have ongoing, you know, treatment management and so forth. But I've been able to like work with other people who like kind of just need somebody that's educated on this topic to talk with their healthcare provider and go with them like virtually, essentially as a patient advocate. And we've been able to like, you know, I've been able to work with people successfully to kind of advocate and explain this condition in a distinct fashion to kind of, I guess, help nudge the provider to maybe go a little bit out of their comfort zone and get the extra MRI, or go ahead and refer to pain management for a blood patch or whatever the case may be. So
that was going to be my question, is what if you don't see a pain management doctor? And I'm so glad to hear that they're looking at the option to trust it, because it makes so much more sense than all these other so much more invasive tests and things to do just to prove something, that it's so much simpler to do that. But I'm so glad that it's changed, but it seems like kind of a hard thing to ask to just try. I even think of it, us in the DC metro area that have some of the best providers. I'm like, I don't even know where I would even go.
yeah.
Like if you, not even just if you don't see a pain management doctor, but even the providers that are here, I mean, how would even somebody do that? Like to even try that?
So there's a couple of options. Like number one, if you have somebody that maybe isn't super EDS aware, but at least is like knowledgeable, right? And is willing to like you can tell that they think, right? Because you've probably all encountered healthcare providers that like they do the treatment by numbers, where they're like, well, the migraine gets the triptan and then it gets, you know what I mean? Like they are very like plug and play, like they're going by like a treatment algorithm. And then there's healthcare providers that you can tell really like understand physiology and they're thinking through and they're willing to like kind of think outside the box with you and things like that. And if nothing else, if they're willing to like listen and try new things to help you, if you frame it from the standpoint of like, look, like I've done the research on this. Here's a link to a webinar that you can watch. Here's, you know, some resources. Like even if you just shared the spinal CSF leak YouTube channel with them, for example, that's really helpful. So you can certainly like, you know, share some resources with them. And if they're like, yeah, like there's no way I'm going to look it up, like that's not going to be the doc for you, right? Or the provider for you. Alternatively, if you have someone who you feel like maybe I have like a decent enough relationship with them where like they'd be willing to entertain the conversation, you know, that's part of where a patient advocate comes in. So there are like board certified patient advocates out there. And then there are people who do kind of like what I do, where basically you can like take me in your pocket to like talk with your doc about it, from the standpoint of like provider to provider. And I really am disgusted with medicine at the fact that like literally that changes things. Like when you bring somebody with letters behind their names, like all of a sudden it's like, oh, like now I can take this patient seriously, which is
I did the board certification
gross,
too.
but
yeah, I have that too, in association with my degree in public health. But you're right. I'm even thinking just like, how would you even help advocate for yourself or somebody else? So that's so helpful. I didn't even know pain management doctors do blood patches.
yes, pain management doctors are like, if you ever need like spinal procedures and injections, in a heartbeat, I would vote team pain management over interventional radiology, unless you're at a specialty center where all they do is CSF leaks, like Duke or Cedars-Sinai, or Dr. Ian Carroll at Stanford is another individual who is like, that's all he does is like CSF leaks basically, but he's also a pain management doc. And the reason I recommend pain management docs is because interventional pain management docs, like literally 2 to 3 days of their week are nothing but spinal injections and procedures. And they do them in a minimally invasive way. That was like what I did when I still worked clinically. And what they can do with a needle and having like years of experience of nothing but spinal injections gives them steadier hands, in my opinion, more confidence with their injecting capacity. Right. Whereas sometimes when you go to like a hospital and you're working,
really good point.
Yeah, because that's what they do all day, right? They're usually injecting steroid, but if you just tell them like, hey, let's like switch the injectate basically to blood, then they'll be like, okay, yeah, like I know how to do that. Like I've really only read about that and done it for like people who, you know, I accidentally punctured their dura, but they know how to do it. You know, it's like effectively the same the same procedure, but just with blood instead of a steroid. So if they do epidural injections or cortisone shots in your back, then they can certainly do a blood patch.
All right, somebody had a question of, do you provide patient advocacy support for spinal and pain issues outside of CFS leagues?
I do, yeah, pretty much like any chronic pain / like EDS and related comorbidities. So like the majority of the people I work with have EDS. I would say like overwhelmingly so. I only have one person who like is maybe on the fence about her EDS, but her main issue is like Lyme disease and mold exposure. So I am not an immunologist. Like I said, my background is in chronic pain management. So anything that's like in the musculoskeletal realm as it relates to EDS, like I am pretty darn knowledgeable on. I'm pretty knowledgeable on mast cell and related disorders as well, since that's like a huge driver of EDS and some of the symptoms that we're seeing now. And then also my area of interest that I'm like moving more into and like have kind of like done this deep dive into the literature because like I find a topic and I'm just like must learn everything about it is ADHD and like neuro developmental disorders as they overlap and relate to hypermobility because there's a huge overlap with those as well. So yeah, I do provide for like a myriad of issues for sure.
Dr. Huberman, he has nothing to do with EDS, but he runs the Huberman Lab podcast. He's from Stanford. Let me tell you, this man, I've learned so much in terms of just like everything you're talking about and just the things that we're trying to make sense of, because I'm like you, I see it and it's like I get deep dive and it just, you're trying to make sense of it. But he is it's so interesting, so helpful on a life skill level, even though he's not specifically talking about EDS, but it's called the Huberman Lab podcast, but it talks about everything about what Briana was just saying in terms of just understanding the different links, and it gives you real good tips to help yourself every day. Somebody said, if a radiologist reported periventricular white matter changes on an MRI, could this be associated with CSF leak? I am just not familiar enough with the details.
I would have to see the image, unfortunately. Like I would have to know like which ventricles they're referring to because there's like 4 sets of ventricles basically. So it would just be, I think, dependent on that. And then I would kind of look at the person, because the thing that I tell all of my future healthcare providers when I'm their teacher is basically like you treat the patient, not the picture. So sometimes we find what's called an incidental OMA, which means we incidentally found this thing and the patient is not symptomatic, right? So, I'm aware of the fact that sometimes like finding those changes on MRI can be contributing, and sometimes they maybe don't contribute. So I definitely look at like the person's overall picture. Let's see.
A good question. If you also have tethered cord, which many of us do, what would be the issue to address first?
That's an excellent question. So I would say being aware of how like tethered cord works basically is like basically you have an adhesion of your spinal cord to your dura, right? And so if you get a blood patch and stuff is healing, that could make those adhesions worse because you're basically putting like a new scab back there in your back. So I am being actually worked up for like a cold tethered cord. And I think at the stage of illness that I was at, like there's things to consider, right? So like if I was relatively functional, right? Like I am now, where I'm like back to work and I can, do a presentation at the end of my workday and that kind of stuff, like where I feel fine. But I'm like, yeah, like I need to get that addressed, right? I probably, if it were me, if I felt generally well, would do the tethered cord first because that's more invasive. And if they go in there and they see, hey, you've got a CSF leak, they probably will address it while they're in there intraoperatively, and you can kind of fix 2 birds with 1 stone at that point. And then there is also more literature that Dr. Kliege is doing with regard to the myodural bridge, which talks about how like the phylum, which is the piece that like tethers the spinal cord to the dura, and the tissues around it interplay with like the muscles and fascia. And so to me, it's like, if you have the access to that type of surgery and the ability to take it off, it might be worth having that discussion with your neurosurgeon. Like, hey, if you find a leak in there, like, what would you do, right? Like, would you fix it? Would you patch it? Like, what would you do? But for me, like it really wasn't an option to have my tethered cord released because I was like literally so sick that like I sincerely felt like I was dying. Like I could not get out of bed. Like I had to brush my teeth in bed, and like really the only time I could get out of bed was like to use the restroom. I was extremely sick. Like I was losing my vision, I was losing my hearing, and like I was losing my cognition to the point where I like could not speak full sentences anymore and couldn't remember like my phone number and stuff. Like I was extremely, extremely sick. So at that point we were just in like, oh my God, like I need to like get help in damage control mode. So I absolutely like, if I were that sick, I would just do whatever I had the easiest access to. And in my case,
I think when I first met you, you had just come over that hump where you had just had, you were not working, you had just had a bunch of procedures and you were kind of, I don't want to say on the mend, but
that's a fair statement though.
You were in that, you were coming somewhat
yeah,
her, but you were still there. And just to see you, I've said it several times, just to see how you have grown and developed professionally and personally, and to see you get back and helping us, it's just, you know, as a friend and a professional, it's just amazing. It's just awesome.
Thank you. I really appreciate that.
Gives me hope. Okay, somebody said, what time is it? Just want to make sure. Okay, 8:40. Are you okay to answering some more questions?
Yeah, I absolutely can. And thanks for hanging on for such a long presentation with me, everybody.
You also have, don't you have a desk that you can lie down and you have your computer up like this?
I do, but fortunately I haven't needed it. I like made myself a sit stand desk. I can actually show you. I like built this desk and it like lifts and lowers basically. Yeah. So I'm like.
But you also have one where you can lay down, don't you?
I do. I have like a lying down workstation.
So. Okay, so somebody said,
oh, I see it.
Someone is already fused and below the thoracic columbar junction, can the blood patch be done for that area?
Depends on your pain management doc. Some patients or some docs will be comfortable injecting in that area and some won't. But in some cases you can kind of just do wherever they're most comfortable doing it. So I've had patches all the way down to like a caudal epidural. So it really just depends on like where they're comfortable injecting. So, and then let's see.
Because we're doing the Metro DC EDS area, you know, a lot of us are in this area, and I know I've asked you this several times, like, where do you go in this area? And
I wish I had a better answer for your area. I'm just starting to get colleagues out in that area, but I'm on the West Coast, so like that's where the majority of my care team is. But the best thing that I would do is I would go on the Ehlers-Danlos syndrome like directory. And then if you are just like, hey, like, I think this is what it is. I like don't have it in me to go to 5 more docs. Like literally the next person I go to just like needs to be a person I can help that can help me. Then go to Duke. Like there's
some people go to Hopkins, but
Hopkins is fine. Dr. Mogakar at Hopkins is somebody that can see people. I don't know how close that is to y'all. My East Coast geography is like not great.
Yeah.
So.
Somebody asked about Philly, but I mean, for a lot of us, we travel a lot, especially between DC, Baltimore.
Right.
Logan Carr at Hopkins.
Yeah, Mogakar. Let me see if I could look up his name.
Any idea? Anybody in Philly? Somebody asked about neurosurgeon, pain management docs in Philly.
Yeah, I wouldn't be able to help you with that. Sorry. Okay, his name is spelled. Let's see. Moghekar.
Logan Carr. Yeah, I've heard, I mean, I have not been to Hopkins for that. I've been for diagnosis and to see Dr. Singman, the neuro-ophthalmologist, but I know several people that have gone for CFS leaks and done pretty well, but I don't know that I wonder about the people that are on the fringe, you know, they're not so obvious.
Right, exactly. So I put Dr. Mogakar's like contact info in
maybe
there.
That's changed. I would love to know if anybody knows that. That would be great.
If what's changed, I'm sorry.
If you know what's happening at Hopkins in terms of like, you know, all the information that you shared in terms of knowing not even the people that might be the slow leakers, like you said, not the obvious patients.
You know, the spinal CSF leak symposium is coming up in February. I want to say it's coming up in oh gosh, I have to look it up, but that's coming up and that's like extremely informative. So if you just go to spinalcsfleak.org, that is like definitely somewhere I would go. And then yes, somebody put the Jefferson Headache Clinic in Philly. That's another good one where they are familiar with like pressure disorders. And then let me look up the symposium for 2021. Let's see. It's going to be October 2nd, so it's actually coming up, and I'll put the link
Yeah, I was gonna say it's
to the
usually in
symposium.
October, isn't it? Yeah.
Yeah, and it's very reasonable for patients. Like they lower the fee. It's more expensive, like if you go as a healthcare provider, but if you go as a patient, it's like not super expensive. I think it's like under $50. And then
Yeah, there was a question about, somebody said, my hearing becomes muffled when I turn my head and tilt it. I turn my head or tilt my head up for too long. Can this be related to leaks? Do you know if convergence insufficiency is related?
So convergence insufficiency, as far as I'm aware, is like more an eye issue. So I think that this person's probably asking about two different things, which is where the eyes kind of like splay out a little bit. So I would say that with CSF leaks, there can be muffled hearing or popping in the ears, as well as, that symptom associated with positional changes. And then also really any issues of the cranial nerves can be attributed sometimes to a CSF leak. So there was a really good presentation like at the 2019 symposium by Dr. Deborah Friedman, and she basically, I think the presentation was called like every cranial nerve basically, and then she like listed the cranial nerves and what they do, and was basically like, I've seen patients with CSF leaks that have had literally dysfunction in like every single one of these, or like one of each cranial nerve, but like they're all different. So she's seen people that have had like balance and just like hearing issues, and that's it. And she's seen people that have just vision issues, or a combination of, the 12 different cranial nerves being affected that there are. So yeah, convergence insufficiency, that's controlled by like the third, fourth, and sixth cranial nerves, excuse me. And so certainly those could be affected by a leak or low pressure.
I think what you mentioned, that not everybody, the headache can also not be the main symptom, is so impactful, not to mention, the vagus nerve impact and the eyes and everything, but also I always heard, if you don't have leakage, like if you don't have leakage in your, like, am I wrong, in your nose?
Oh yeah, so somebody actually asked
like
that.
They looked at, yeah.
And so somebody asked about like testing the fluid from your nose, like if you do get leakage from your nose. And so that's actually a cranial CSF leak, and those symptoms can overlap. So some people that are even the leaders in this will say, like, if you have leakage from your nose, that's a cranial leak and not a spinal leak. But I have two friends who have had like the nose leakage and then got blood patches, like, and treated it basically like a spinal leak, and they got better. So I'm sorry, you cut out.
What about fluid in the ears?
So if you have fluid draining from the ears, I would absolutely seek like emergent medical care for that, because that could lead to like meningitis basically. So yeah, if you have like true fluid from your ears.
You have fluid in your ears?
Yeah. Oh, like fluid draining from your ears, or do you feel like the feeling?
It's very
So a feeling of fluid or fullness in your ears is a little different than like if you actually have like clear fluid coming out of your ears. If you have clear fluid that's like coming out of your ears, like you're putting a tissue and you're like, oh, there's fluid coming out of my ears, you should absolutely get like immediate medical care for that, for sure. But if you have that feeling of fullness or like shifting fluid inside of your ears,
or like
then,
you have water after you went swimming, it feels like that, but you didn't.
Yeah, like fullness, that's absolutely one
yeah.
of the symptoms
Really
that's been described. For sure. But somebody put like, can you measure if you do have fluid coming out of your nose? Can you measure that with a glucometer? Like, yeah, you can actually, and you can test it with a glucose strip basically. And it has a higher blood sugar than like just your snot would basically. Let me see. Someone also asked, you mentioned steroids being detrimental for people with EDS. Daughter has been diagnosed with EDS and comorbidities. Histamines, negative effect on breathing. Something we should be concerned about. I would say that inhaled corticosteroids are a little bit different than like injectable corticosteroids. So pulmonology, and specifically like pediatric pulmonology, are like unfortunately way out of my wheelhouse. So I would bring up any concerns with any physician you have. If you're ever concerned, just generally, you should certainly bring that up and just say like, here's my concerns. I know steroids can, cause thinning of tissues over time. Like, is that the case with, an inhaled corticosteroid? And, certainly just bring those concerns up. You should always bring up concerns that you have to your healthcare provider. Let's see. People ask, do people like Henderson know a lot about CSF leaks, or is Duke much better? Try to be like professional. So if it were me, I would go to Duke. That is the best way that I will say that.
Everybody's got their specialty.
Yes.
Right?
Yes.
If you're
exactly.
We're looking for somebody that has more knowledge when we talk about the people that are on the fringe to really try to figure out,
Yeah. And somebody put in here too, like that atlantoaxial instability can cause issues with like head turning and stuff. It absolutely can. And they put, make sure to rule that out as well. I would absolutely agree that you should continue to work these things up, because you can have all the things at once when you have EDS.
Yeah.
Like I had,
a lot of
POTS,
things can be
leaks,
true at once.
dysautonomia,
Isn't that
CCI.
right? Yeah.
Yeah, but like the way that I said, okay, like I need to get patched is basically I like wasn't having meaningful improvement with a hard color. Like I did all the stuff for CCI and still wasn't like seeing meaningful improvement. So then to me, I was like, okay, this isn't the main driver of my symptoms. Like I still feel like crap every day, basically. And it's the same if I have a neck brace on or not, and now just like the bottom of my jaw hurts from being resting on this brace all the time.
I remember being told to take his hands and put it like hold up my neck.
Yeah.
But it's like pretty hypermobile. And
yeah. But yeah, I mean, and that's like the really hard thing about all of this, right? Is like you might not ever get like a clear cut answer, you know what I mean? But to me, it's like, okay, if you've got 3 things and let's just call them like Chiari, CCI, and a leak, and you're like, I'm not sure which of these it is, right? Well, Chiari and CCI, you literally need like irreversible surgery to effectively treat those, right? So if it was me and I had like a, possibility of any of those being my symptom drivers, like I would try the least invasive thing first, just because I know that staying neutral and doing nothing isn't an option. And I certainly would not want to get, sorry, my doggies are like walking by my curtain. I certainly wouldn't want to get an irreversible surgery if I wasn't 100% sure that I had ruled out every other thing that it could possibly be.
So glad
because
you brought that up. Somebody asked, well, how do you get us full workup?
I think that you need to go to somebody who's aware of these conditions and EDS, and who will order the appropriate imaging for you based on your symptoms.
Okay, I'm glad you brought up. I think we've answered. Do people? Okay, we already answered that. I'm so glad you also mentioned vertigo. A lot of people suffer from vertigo or start suffering from that. You mentioned about weight gain. What about fluid retention in weird areas, like just gaining weight and just, you mentioned hormonal changes. I just think about how many people just, you shrug it off to like you're getting older or something.
Yeah. Yeah, it can really be variable.
Fluid correctly.
Yeah, no, it can really be variable. Yeah. Like to this day, I have like a lipedema deposit on only my right ankle, not my left ankle.
About too, like this whole it's lipedema. I'm like, okay.
Yeah, that's what they're telling me. But hey, like I will take my little lipedema bubble. It's like, I would say probably the size of like half a tennis ball if you put it on my ankle. And it looks a little funky. Like I'm not in love with it, but I mean, hey, like
I just think if that's the remedy I'm hearing more and more about,
yeah,
and it makes sense, but it makes me wonder just,
yeah, I know.
Makes you go,
Yes, things that makes you go,
Yeah. That's all I keep thinking. I'm like, especially when it's just not typical for the person. Even if they have all the things, they still know their body. We're all different. And if something is just still, even if you have 20 things, and a lot of us do, if something changes suddenly in your body, and even though it could be typical under that, if it's not typical for you, I don't think it just happens. So
I agree.
I
totally agree.
I love this. Thank you. I'm so glad that you did this.
Thanks.
We'll make sure the slides are available. I will try to get the recording done and up so that people have it. I also I can link to your previous one, although the information you shared a whole bunch of new stuff too.
Thanks.
Great, and the interaction.
Thanks.
Anything else?
Appreciate it. yeah, I know if anyone wants to get in contact with me, you can reach me at healedandempowered.com. That's my business name.
Yeah. We'll
And I
make
have
sure
like imposter syndrome about it too. Like I like went back and forth
you
with
do.
somebody and I have like the
It's all-
ultimate imposter syndrome. Yeah, it's like, I don't
Yeah,
know.
but you rock, and I'm so proud of you. It's awesome.
Thank you. I appreciate it. I'm like,
you're so great at teaching and helping us, and like,
thank
awesome.
you. I really appreciate that. I'm like gonna do my best to like integrate that and not like push back with like a
Right, well,
yes,
and
but like
yeah,
like thanks therapy.
but you always rock it, and it's so helpful.
Thank you. No, I appreciate the opportunity. Someone asked me to put the contact in the chat. Yes.
Yeah, contact in the
Thank
chat. I'm gonna do that, and I'll make sure that I also put it when I edit the video, and I'll put it in the thing, the video too, on the video.
Thank you. Yeah, I'll
Lack
get you
of
the
words
link,
right now.
Kendra, for
Saying
the.
and pronouncing words is not my forte right now.
That is a-okay. I will send you my my presentation, like the link for the presentation basically, and you can feel free to share that one.
Okay.
And then
The email is healedandempowered@gmail.com right now, right?
yes, it is. Eventually I'll port it over to like a more professional one, but right now I'm a one-woman show and that's just
You're
I'm a little.
You're making change in the PA world.
Thank you. Yeah, I'm like, seriously, it was the best feeling in the whole wide world. One of my students was like, I diagnosed a CSF leak in a patient and my doctor didn't even know what it was. I was like, yes. Like, it was seriously just like.
Well, and plus
like,
you're a patient. You got your own thing going on, and you've got your husband, and like, it's awesome. Thank you.
Thank you.
So much for what you're doing.
Thank you. Thank you.
Here.
Yes, no, I know. Well, maybe I'll come
Someday.
and like go to the East Coast and just like go visit you at some point now that I'm healthy
Or
enough
I
to
should go
travel.
out there.
Woo. Yes.
I can escape. I got the 3 kids. I can go.
You're like, let me escape.
I did get my vaccine, so I got the vaccine. I'm good.
Awesome.
Now
I'm glad that you are healthy and vaccinated and doing well with that. So thanks everybody for having me.
Thank you. And we'll
I
make sure that we
appreciate
get
it.
everything that Briana mentioned.
Oh, sorry. Dogs in the background.
We'll make sure that we get everything that Briana mentioned in terms of links to contact her and other resources as well. So thank you. Bye, everybody.
Thank you. Kendra, I can stay on if you want, like after you close it.
All right, give me 1 second.
I'll let you close up. I'm going to let these doggies outside really quick and I'll be right back.
Okay.
Thanks, everybody. I'll be right back, Kendra.
Bye, everybody. Oh, she's still screen. Briana, you're still sharing the screen. I can't cancel out.